Good afternoon. We are very excited to have all of you join us for the 21st Dental Education Network for Texas, DenTECO. This session is brought to you in collaboration by the Texas Association of Community Health Centers and UT Health San Antonio. And Taylor, if you could please share the announcement slides, that'd be great. And I'm Kato, and I will be assisting in facilitating today's session. Next slide, please. And here is our agenda for today. We'll start off with some announcements and introductions, then move on to didactic presentation by Dr. Lewis and case presentation by Dr. Shakir with time for Q&A at the end. Next slide. And some notes before we get started. These sessions are recorded for later distribution on our DenTECO website. And please stay muted unless you're speaking. And the slides and recording will be made available on our DenTECO website post-session. And to help us with attendance, please enter your name, affiliation, and email into the chat. And please remember that no personal health information is allowed in either the chat or our discussions. And if you would like assistance with your connection throughout the session, please chat Taylor or Dent Echo. Next slide. And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. ECHO is an all teach, all learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. Next slide. And to receive CDE, CME credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, please make sure to register through Smile, which you can do so now using the link in the chat. And when registering, please use the supercode ECHO 2024. Thank you, Taylor. Please unshare the slides. All right, thank you. And from the Dent Echo Hub team today, we have Kathleen. I'm not sure if Dr. Malaha or Dr. Rankar were able to join, and I see Dr. Dar. Thank you. Dr. Dar, would you please introduce today's speakers, Dr. Lewis and Dr. Shakir?
Absolutely. Thank you so much, Ms. Kawasaki. It's my absolute pleasure to introduce our two presenters for this afternoon, Dr. Shirley Lewis and Dr. Hala Shakir. Dr. Shirley Lewis earned her dental degree from India, followed by a pediatric dental residency and a master's in dental public health from Boston University. She further specialized in forensic odontology through a fellowship at University of Texas Health Science Center. So that's her UT Health San Antonio connection. Currently serving as the clinical professor at Texas A&M University College of Dentistry in Dallas, Dr. Lewis has dedicated her career to practice teaching research in public health, forensic odontology, and pediatric dentistry. She actively engages in consultancy and pro bono work for various state, national, and international organizations. Thank you, Dr. Lewis, and welcome. Next, we have Dr. Hala Shakir as our case studies presenter, and she also has a UT Health San Antonio connection. She was one of our dental public health residents a few years back, so it's wonderful to have you back as a presenter for our DenTECO session. A little bit about Dr. Shakir and her accomplishments thus far. She has been practicing dentistry for 2 decades now. Dr. Shakir completed her dental degree in Baghdad. After practicing for a couple of years, she moved to the United States and equalized her dental degree and became a licensed dentist in California. Dr. Shakir pursued nonprofit work and was dedicated to providing care to vulnerable populations, focusing on developmentally and medically compromised individuals. She was also an assistant clinical professor at Western University School of Dentistry in California. Moving to Texas, she earned her Master's of Public Health from Texas A&M and a residency with us at UT Health San Antonio. Welcome, Dr. Shakir. Welcome again, Dr. Shirley. We look forward to this wonderful presentation this afternoon with both of you.
Thank you so much, Dr. Dar. And Dr. Lewis, whenever you're ready, please share your slides and please take it away. And to everyone, please post any questions in the chat during the presentation. We will address them at the end. All right.
Thank you. Thank you, Dr. Dar, and thank you to the ECHO group for inviting me and allowing me to present on this very important topic. I'm going to start off with sharing my slides here. Let's see. Okay. Let me know if it's not easy. Okay, can you all see my slides? Okay, well, thank you. I appreciate the opportunity from Dr. Dar and Dr. Uranker, who actually initiated this conversation about me presenting on silver-diamine fluoride. So I appreciate that. And it's good to come back to UT San Antonio to do this presentation, even though I was on a different leg at UT San Antonio for forensics. But I'm glad to be here because I know how much SDF has played a role is playing a role in public health and in private practice. So that has been part of in academics, it's taken a major role. And so that's the part of my presentation today, is to focus on the didactics, while Dr. Shakil will focus more on cases that she has worked on and go from there to show the whole clinical aspects of SDF. So my objectives for today's presentations are threefold. I want to talk a little bit about the scientific aspect, bring in a little bit of the knowledge and understand why we are using it and when do we use it. And then, of course, master the techniques of when we are going to place the SDF in clinical practice. So when I want to disclose first that I have no financial, referendums or any kind of disclosures with any companies, with any organizations, with any universities. So this is all based on academia, based on research, and no disclosures whatsoever from any organization. I do want to start off by acknowledging a few people, including all the 4 people that you see on the slide are people I have learned about SDF. I did not learn about SDF when I was doing my residency in pediatric dentistry or in public health, because that's how old I am. Because at the time it wasn't very prominent. Maybe it was being used in Japan and countries in Asia, and other countries, maybe a few countries in Europe, but wasn't prominent in the US, where I did that extra training. And so I learned from these 4 individuals who are very prominent in minimal invasive techniques. And so a lot of my slides are based on what I learned from them and slides that I took from them, and research that is from them. And I also want to acknowledge my father, who was part of the reason why I'm here today presenting to all of you. I don't know if that's good for you or bad for you, but that's why I'm here today. It's his push and encouragement that has led me to where I am today. So let's start with what is silver-diamine fluoride. I'm assuming some of you already know about it. Some of you are just here to brush up on it. It's basically a blue liquid, that has antibacterial effects of silver with remineralization power of the fluoride. Now, the APD, which is the Pediatric Dental Organization here in the US, also, they came out with their guidelines. They came out with their statement back in 2017, and that's when it took got some kind of leg in the US between the APD and the American Dental Association, where they started to consider it as a non-restorative management technique, especially specifically to arrest progression of small cavities or teeth that were cavity susceptible. So when we move on, the the American Dental Association and the World Health Organization also came out with their statements in 2020 and 2021. So this was like extra validation from these two other main organizations. I haven't mentioned the FDI. FDI did come up with a statement too. So we have all these major organizations, you know, putting their word out there, backing the research and the science behind the use of SDF, all talking about the antimicrobial use, talking about it being remineralizing agent, and also about how it's like a medicine that, you know, all governments should ensure that the WHO considers that should be available and affordable to all populations. So just briefly, this is how in the US, and I think Canada adopted it a little bit earlier, but in the US, we first started having FDA clearance for hypersensitivity. That was for the first aim that they allowed it when, you know, Asia was using it specifically. I think it was Japan. And then by 2016, we already had a code, you know, for as an arresting medicament application. By 2021, we had it as a preventive. We had an actual code for preventive and public health practice that we could use towards preventive medication. So there has been an evolution of how we have adopted SDF in this country. Same way, you know, JADA, which is the American Dental Association Journal, came out with practice guidelines, you know, and that's when people started paying attention. When the American Dental Association puts out guidelines for a specific treatment, specifically when they start calling it the non-restorative treatment for carious lesions, it starts gaining momentum. And that's what happened, and where people started even teaching it in, in academia. So what is SDF, sorry. It is basically a colorless liquid, like I mentioned earlier. It can be a slightly tinged blue liquid with a pH from anywhere from 10 to 13, depending on the manufacturer, and we'll see that later. It has three main components. You know, the solvent is water, but it has silver, ammonia, and fluoride. And what silver does is it's an antimicrobial agent. And ammonia is a solvent, while fluoride acts as a remineralization agent. So those of us who are in dentistry know what fluoride does. But what silver is doing here is doing the whole antimicrobial agent part that we need here. And the slide says 44.800. Sorry, my throat just got suddenly dry. Excuse me. It actually should be 44,800. I'm sorry about that slide. I just noticed that, and that's why I wear glasses. But if it's 44,800 parts per million in SDF, okay, compared to when we compare, if you compare it to varnish, so fluoride varnish, which has 22,600. If you look down here in this middle category here, 22,600, and silver diamine fluoride has 44,800. So with silver diamine fluoride, they started off with saying an extreme risk, but now we've also started adopting it in moderate risk, sometimes maybe in mild risk. And there's validation for why we would do it in all these different individuals. So SDF, what does it do? Like I said earlier, it arrests dental caries. We found that that happens in about 81% of the cases when you do it at least once or more than once a year. And it prevents caries in about 62% of the cases, directly or indirectly. When you say directly is when you're applying it directly to the lesion. indirectly is when a surrounding lesion or a lesion that's nearby gets a little gist of the SDF, or you're applying it on a high-risk individual and you're trying to prevent caries, then that's your indirect way of preventing caries. And then, again, as we started earlier, it was to decrease dentin hypersensitivity. And one of the things it does, which is more of a disadvantage, but it works well still, is it turns the D or hypomineralized areas dark or black. How does it work? It has, like I said, the bactericidal effect, prevents bacterial growth. It remineralizes the lesion, converting to fluorapatite. It increases the lesion hardness. So that's what we want, so that we can put in a final restoration, and so that we don't have any of the soft gooey stuff, which would be the progression of the lesion. And also it occludes the dental tubules, so preventing the bacteria from penetrating even further into the dentin and pulp. Now here is a slide that most presenters would use, because it kind of explains to you how far the SDF is penetrating in. If you had to measure it in millimeters in the tooth, you would think the research has shown it goes about 2 millimeters into dentin once you place it over dentin. If you had to measure in microns, it's about 25 microns into the enamel, which is this little top layer here. And then when you talk about into the dentinal tubules, it penetrates about 200 microns into the dental tubules, and it hardens that. So when it's hardening that, it's preventing the carious lesion from progressing. So it's a combination of events that's happening here in this area. For those of you who are interested, it's the silver protein conjugates, it increases the density of the minerals, right? And that means it's increasing the hardness around the dentin there. Fluorapatite forms, and that increases your resistance to acid in your carious lesion. And then you have the inhibiting of proteins that break down the dentin. So it has this combination of all these effects that happen while occluding these dental tubules. So, back to the basic science is that, when it first came out, it was this hardening effect and preventing. It wasn't just us putting like a liner or a base and closing it up. It was actually going into the tubules and preventing even further bacterial growth or bacteriostatic effect that it had, that was helping it have even better results. Some of the advantages of this is it's painless. You don't have to use anesthesia because there's not much decay removal. Of course, you're going to clean the area to remove any plaque or debris in there. It's applied usually in one visit as soon as you diagnose the decay. Little prep time. When I say prep time, I mean just cleaning out the lesion. And then when you apply or paint the SDF, the minimum time you need is at least a minute, right? Some people like to keep it on for 3 minutes before they release the patient or put in a final restoration if that's the way they want to proceed. And then it's affordable. So it's affordable from a public health standard point of view. It's affordable definitely from a private practice point of view. So, and we'll talk about this in a future slide. It's like when a patient who does not have even access to care issues in public health, for rural communities, this makes a huge difference because at least we can buy time. When you're at a health fair or any kind of thing where a patient has an access to a dentist for a short period and they need time before they can actually go and get final treatment. So this actually buys time in a public health setting such as access to care issues. So the big advantage here is the staining and, you know, turning the structures black, as you see in the pictures in front of you. And then there is the bad taste. It does not offer like a final restoration, obviously, like I said, and it's not a long-term remedy. And but at least we are at least trying to a huge percentage of, you know, progression of lesion. It's just not pretty, that's all. The affordability, you know, a lot of patients, when obviously from, you know, everybody, you know, we can think about it, depending on their background, financial issues, like I said, access to care, medical complications, you know, they choose to go because it's affordable. It's they don't have to deal with the fear of dentistry. I mean, at least we can buy time is what I'm trying to say here. It's too, and sometimes as patients, especially from a pediatric standpoint, they're too young for the OR. So before we can get them to the OR, we don't want those lesions to progress, so we paint them on, right? If a tooth is close to exfoliation, a parent is like, I don't want to deal with taking the tooth out. I don't want to deal with giving my child anesthesia. Sometimes they cannot afford the OR, or they cannot afford nitrous or any kind of sedation. Sometimes there's medical complications, whether it's an adult patient or a child. And, you know, between the parent and the guardian or the individual themselves, they don't want to deal with anything else. So it's a very affordable, from that standpoint, it's very affordable. So the APD in May 2021, they also had some pros and cons that they listed. Most of them I've already touched on so far. One thing I do want to point out is the cons part, which you see on the right side of your slide, which says that it's not a cure for caries. And the cure is kind of a really strong word there. I don't know what it would be a cure for caries unless you took a tooth out, right? So cure would not be the best of words. But it is a kind of a prevention. It's kind of a treatment for caries, at least to prevent caries from progressing or from happening. But you know, they have listed everything that I've talked about so far. And sometimes you may need to reapply some of these, the lesion, because sometimes there will be a small percentage of teeth, and based on the patient's habits or dietary habits specifically, whether, you know, they will be exposed to more plaque or any other kind of areas that the oral microbes cannot be controlled in their mouth. So the reapplication is deemed necessary in those cases. We'll talk about protocol in a bit. And when it comes to pregnancy, you know, we don't have any studies that we can talk about that say, you know, oh, you know, it's definitely safe. But obviously, if a woman is allergic to silver ammonium fluoride, they're not going to use it. Though there was a statement that was put out there that there has, obviously, since there's no studies, there is a long history of silver nitrate that has been used on women to cauterize warts on the cervix of pregnant women. And I quoted all the studies in all my slides, so you can look it up. So they have used silver nitrate for HPV warts. And so instead of using SDF, they recommend the combination of using 25% silver nitrate and fluoride varnish to have an equivalent effectiveness, has been shown to have an equivalent effectiveness to SDF. So that is something to consider in pregnant women instead of SDF. Contraindications, obviously any allergies to any of the above. Thyroid gland therapy, specifically with VivaStar. It's an Australian product, which is also available in the US and Canada. I recently came across that, is that thyroid gland therapy, it's contraindicated. And definitely when there's direct pulp exposure, irreversible pulpitis, and any direct muco or gingival lesions, you are not going to paint SDF on. So those are definitely the main contraindications that you would not even consider using SDF. And this is, molar incisor hypomineralization that we see in kids and sometimes goes undetected and is still there in adults. Dr. McLean and Horst have, they have done a lot of, they've posted a lot or revealed a lot of their work that they've done, used SDF and restored with either glass ionomer or any products. And you can see here the before and after. It doesn't always look that pretty, but at least it stops the lesion and prevents further pain or any other symptoms. And especially when it's a posterior teeth, mostly parents and adults are not as concerned or picky about it. Populations used mostly in pediatric and geriatric dentistry, in nearly 80% of the population. And like I mentioned earlier, rural practices, that's where the equity issue comes in. So, this is something that is affordable and can be used in all populations. Special needs, sometimes there's times when we cannot get to them, or they cannot get to the dentist, or they cannot get to getting dental treatment. We have to buy time for whatever reason. And so we use SDF. And then disease treatment or prevention, and obviously health promotion. So the public health standpoint, it's a huge help. And then in general dentistry, if those of you who see adult patients also, anything under your crowns and bridges, any indirect pulp caps, initial caries, lesions, root caries, secondary caries, sometimes you think like if that secondary caries is just really initial, you don't want to replace the whole restoration, or a patient doesn't want to extract the tooth. So there is so many, we can go back and forth and say, we can go back and forth and decide, well, I would like to do this and the patient does not want to do that. So at least SDF gives you that alternative of, okay, preventing progression of lesion. And then there's the smart restorations, which is, some of you may have already learned or be doing it, which is the silver modified atraumatic restorative treatment. There are 2 SDF products in the US, which the 2 products are Advantage Arrest and VivaStar. Both have 2 different kinds of 2 different pHs. One is 10 and one is 13. With the with Advantage Arrest, you have the bottle version, and then with VivaStar, you have the bottle version while you also have it comes in capsules. And it's about I think 260 microliters per treatment visit. So you have 8 drops in there. And if you look at the price cost per treatment, the bottle, it's about 70 cents per drop. Now this is from a few years ago. So considering inflation and stuff, I would assume it's a little bit more than that today. But it's still, for 38% silver for Advantage Arrest, that's a pretty good, when you're trying to play prevention or arresting a lesion. And moving forward, here is the setup. I just want to go over really quickly about the setup. This is, you have your Vaseline, your cotton rolls, your dish to place your drop, and your varnish. You have, obviously, with every procedure you would do in dentistry, you would have informed consent. Here too, you have informed consent. Informed consent specifically here, and there's, like you see the image that I have on the screen, it covers everything, including the, it's looking into the consideration of the medical and dental needs of the patient. But also it brings to the patient or the guardian and the parents, notice that there's this picture that shows that the tooth is going to turn black. So they know what the tooth is going to look like after you paint the SDF. So most of you may have done that, and if not, that's one example of a consent form. You can use that or change it around, make your own, as long as you have all the benefits and risks and alternative treatments listed on there. So you should be fine. And the site that I've listed here, which is by Dr. Jeremy Horst, it has all different consent forms in different languages. It's, I think, about 6 languages, from all the way from Arabic to Somalian to Mandarin, Spanish. So it's good if you wanted to, in any of those languages, it's a great resource to access those informed consent forms. And again, here back to how do you use it? The short version, you isolate it, you air dry it, you apply it with a micro brush, leave on for a minute, let it, just leave it, let it dry by itself, and then protect it with a layer of fluoride varnish. It's very straightforward. Like, so really in 1.5 to 2 minutes, you really can get this done, okay? Especially one tooth, with one drop of SDF, you can treat about 5 to 8 surfaces or teeth. The longer version of what I just said is I would recommend you use protective equipment, have the patient wear safety glasses, things that we would do for any other procedure. Plastic lined bib is really important because it will stain surfaces in your clinic. Patient's clothes, you don't want it to, if for any reason you drop something on your patient. So you dispense it onto the Dappen dish, and, it says here to 5 surfaces, but you can go up to 8, depending on how big or small your surfaces are. Before that, you'd want to apply some scented balm or on the patient's lips, just so that to prevent it from sticking on or staining the patient's lips, and maybe some toothpaste on the tongue to mask the ammonia taste. Use a saliva ejector, and then isolate the tongue and cheek, and then, like I said earlier, dry the tooth surface, apply it, and like in Dr. Horst's words, say goodbye. You apply it, you leave it on for a minute and remove the excess, cover with varnish, and then that's it. Okay, make sure you also dispose off everything in the trash can immediately, rather than leave things lying around and everybody else touches it and gets stains all over. So protocol wise, when it's mild caries, the most important is like severe caries, but people have started using it for mild caries, because then there is the access to care issue. You could do it even just once a year, for if it's but some people would like to do it every 6 months. That's up to you and where your practice or what kind of setting you are in. In moderate caries, every 6 months with 1 2 to 6 week loading dose. In a severe caries, you would do it every 6 months with 2 loading doses, which is approximately 2 to 6 weeks apart, and then again after 3 months. So you're really having these like 4 times in severe caries. So this way you're kind of controlling the progression of the lesion, just because there's some other risk factors happening in this patient that you're trying to fight the time and fight the lesion. So obviously you're going to do it more times. Acceptance of the treatment, SDF, most patients, when they did studies, only 2.7% declined treatment. Most were very accepting of the treatment. on another study by Crystal et al. If it's in the posterior tree, and a lot of parents preferred this rather than any kind of sedation or general anesthesia. So it's been a really highly acceptable treatment from many standpoints. Now, I included this slide here just because here, in this situation, here, back here, patient does not want to extract, or maybe you don't feel there's a need to extract, you want to leave the teeth just for, functional use, but you think that, hey, there's caries happening below your restorations or difficult to reach areas, and difficult to access and clean. So you could paint your SDF there in your older individuals. Same thing that I said earlier, the staining of skin. And Mr. Clean, that is available, at least here in the US and Canada, is one of the things that is recommended to be used to remove, that supposedly helps to remove it. The stains. Otherwise, it's just a tattoo you're going to live with for a few days or weeks if it falls on your skin. And that's something you'd have to inform your patient. Riva Star is one of the other products that I mentioned earlier. It's a little bit more expensive than Advantage Arrest. It comes in, the pH is a little higher here. It's SDF with potassium iodide. So it's highly, highly recommended that you use it with a rubber dam or some kind of gingival barrier because it can burn the soft tissues. So you've got to be really conscientious about that part of usage of Riva Star. Now, it comes in bottle form, it comes in capsule forms, and then they have the Riva Star Aqua, which is without the ammonia, which makes it less of the bad taste. So they say it does not have a bad taste. I personally have not used it. But from my colleagues who they said the patient acceptance is really good with it because they really say they don't taste it. And but obviously the big thing is having to use the rubber dam. You cannot get away with just using a saliva ejector or something. So and then the manufacturer definitely says the best way, and of course it does not have the staining capacity as like Advantage Arrest, from what I understand. They recommend you restore with glass ionomer to prevent the restoration and margins from staining too. And I alluded to SMART earlier. So SMART is really silver modified a traumatic restorative technique, which is SDF and glass ionomer on the same appointment. Since we're not talking about SMART treatment today, I just want to kind of give you an idea of what it was. And a few slides later, I just have a little explanation of what it is. I may not get into the details of it, but at least it'll be there on slides for those of you who are interested to actually learn the technique or just brush up on it. And here's silver diamine fluoride. The CareQuest came up with a graphic representation. Basically same thing of what I said earlier, and then for the current and future, what's there, when it comes to minimally invasive techniques, we have the Hall technique. We have SMART, which I just said, it's the whole explanation, the step-by-step techniques are all here. You can actually download, pick up the PDF format of this. It's on my, the references, it's on there. I have it on my slide. I think the next 3 slides, it should be there. And then we have the povidone iodine 10%, which is another, for the sake of time today, we cannot get into the details of this, but I wanted, for those of you who are not aware, to be aware that there are these other options to prevent incipient lesions from progressing. So all we're doing is playing this huge prevention and arresting game that we did not do as much before, and we only depended on fluoride or fluoride varnish or gel. So now we have so many more options and so many techniques of placing crowns or restoring teeth without without getting too what is the word I'm looking for? Without getting too ingrained on anesthesia and sedation and everything. So the other options. And a few points I just want to make before I wind up my slides. Oh yes, so SDF does not increase blood fluoride levels, and caries prevention in the elderly, it does help. It prevents caries in the root surfaces better than fluoride varnish. And then this one also it has helped in reducing gingival inflammation and plaque accumulation. Some of the codes that are on here, I've included for your information, and some here are some videos and online info of some techniques and of all the stuff that I mentioned today. And I would like to thank you all for I know I went a little bit over. I'm sorry. I was waiting for someone to tell me. But sorry about that. I hope to give Dr. Shakir her time right now. And we'll address questions at the end today. Thank you.
Thank you so much, Dr. Lewis. And please remember that the recording and slides for this session will become available on our Dentaco website after the session. Let's move on to the case presentation from Dr. Shakir. Okay.
All right. Good afternoon, everyone. Thank you, Dr. Lewis, for this thorough presentation. And today I will be presenting a couple of cases that are a part of my study that took part in a nursing home facilities in San Antonio, Texas, throughout my residency with UT Health San Antonio. First and foremost, the objectives of this presentation of the cases that we're going to look at how well SDF works and some of the success rate. Also, we are going to discuss how SDF meet the Institute of Medicine 6 equality aims, some side effects. I know Dr. Lewis went through them into detail, so I'm not going to go there, but they are in the slides if you guys want to look at them. And while we are providing supporting evidence for the use of SDF as a non-restorative treatment options. A little context here. I know this slide, Dr. Lewis went really well on the composition, so I'm not going to go into detail on that one. And this infographic on the right side is basically what she showed you as the microscopic levels. But this is more of a infographic to understand how the silver-diamine block the tubules and prevent the caries from progressing to the pulp. This is some study based on the current best available evidence. There are studies like umbrella reviews, there are systematic reviews, randomized control trial, all saying that and showing that SDF can be used by dental professional as a non-restorative treatment option. And it shows also that how SDF can arrest coronal caries in the primary dentition and arrest root caries in adults. And if you guys, I have it all in the reference. If you guys wanted to have more details, you can check them out. There is a 2017 meta-analysis compare arresting of primary teeth using SDF and also other treatment modality, and it shows that SDF is more effective. And SDF was cleared by the U.S. Food and Drug Administration as a treating tooth sensitivity and will be used as off-labels for caries arrest. Another reason for why SDF should be used in the clinical setting, it's because it meet the Institute of Medicine 6 quality aims, which is the Institute of Medicine identified 6 crucial domain of healthcare quality, and SDF meet all of them. They classified as being safe, effective, efficient, patient-centered, equitable, and timely. The International Caries Detection and Assessment System, also we can call it ICDAS, developed to bring forward the current understanding of the process of initiation and progression of dental caries to the field of epidemiological and clinical researcher. It's actually provide clinician, researchers, and epidemiologists with an evidence-based system which would permit standardized caries detection and diagnosis in a different environment and a different situation. So for here, it's actually, there is a score 6 categories from score 0 to score 6. The cavitated one, the one that you clearly see the cavitation, is a score 5. It's a category 5 and 6. When you have a clear cavity with visible dentin and extensive clear cavities. Adverse effect, I'm not going to go through them because Dr. Lewis went really in thorough for them, but the main thing is the stain. And also there is some patient reporting some allergic reaction, some adverse reaction after they apply SDF. And that manifested with a small white lesion of oral mucosa that will disappear within a course of 28 hours. But despite all these side effects, the acceptance rate is high, and that perhaps due to this SDF is easy to apply, and there is no drilling, no anesthesia. It's basically pain-free approach. Now we're going to check into the cases that I would like to present for you. The first case, we have 63 years old male. As you can see, medically compromised. Patient has type 2 diabetes, depression, hyperlipidemia, bipolar, epilepsy, anemia, and taking many medications such as bupropion, Cymbalta, insulin, furosemide, metoprolol. I mean, these medications, yes, we do not prescribe this, but we are definitely familiar with some of them, such as the bupropion. We know and we use it in dentistry for smoking cessation, but here used as an antidepressant. And with this medication, they have one thing in common. They all produce xerostomia, induce xerostomia. And we know xerostomia can exacerbate the caries disease process. And this patient, you can see, have 19 teeth decayed, 14 of them are category 5 and 6. This is before and after pictures after a single application of 38% SDF. So the dental caries, normally it's soft and brown in color. So once we apply the SDF, notoriously become dark and hard. And that's how we assess if the SDF is working or not. Is it successful in arresting the caries or not? By color and texture. So the darker, black, and hard texture with no association symptoms of pain or discomfort, considered successful. So in this case, we achieved some success, but not all of them. I want you to look at tooth number 23 and tooth number 25. You can see they are partially arrested after a single application of SDF. So this actually consistent or aligned with the American Dental Association Center of Scientific Affairs and Center of Evidence-Based Dentistry, where they report that their report suggested that low certainty evidence for the use of SDF in advanced cavitated lesion. So the challenge here in this case is not only the patient have advanced lesion, but also exacerbated by the xerostomia-induced medications, personal factors, social factor. So all these factors potentially overwhelm the antibacterial capacity of the silver in the silver diamond fluoride. So one application will not be enough to control the caries in patients like this. Here, the picture, you can see it on the right side. It's not for you to memorize, but rather to put into perspective how caries is a multifactorial disease, and many factors can impact the caries disease process. And in this case, we have the polypharmacy, multiple medication given to the patient. We have medically compromised patient, anhedonia, secondary to depression. I'm not sure if anybody by any chance knows what's anhedonia. Anyway, so for the sake of the time, I'm going to tell you what anhedonia is actually lack of motivation. Patients here feel no interest in cleaning, grooming, or brushing their teeth, and that will be exacerbate the caries process, and make it high risk for caries, for developing dental caries. Besides the dementia and the lack of dental insurance, we know these patients that I'm showing you today, they do not have dental insurance. They haven't seen a dentist for the last 5 years. So imagine, so lack of dental insurance is actually a big barrier for adequate oral health. Second case, we have a 75 years old male. Also, you can see medically compromised. And this patient diagnosed with the cerebral palsy. Taking medication, multiple medication was given, 3 or 4 medication as antidepressant. And those medication all have the same thing in common. They produce xerostomia. They induce, xerostomia. Xerostomia can exacerbate and complicate the caries disease process. These patients have 12 teeth remaining. 9 of them were category 5 and 6. This is the patient oral health condition when I saw him. I'm sorry for the picture on the left side. We were trying so hard to get a good picture of his mouth. He moves constantly. We would not able. But imagine this mouth. I know maybe this is not coming to you in your clinical. These are very, very specific cases. But yes, cases like this can be treated with SDF. This patient's medically compromised, no insurance, cannot stay still. How can you do filling or even extracting his teeth? So in this case, we ended up treating his whole mouth with SDF. But in the second picture here, I'm focusing only on the right side. For the sake of the study, I want to show how SDF works. So we apply single application of 38% SDF solution, and we achieve success in this case. And then again, we achieve success because the 2018 American Dental Association Center of Scientific Affairs guidelines on non-restorative treatment for caries lesion, which Dr. Lewis mentioned also in JADA, published in JADA, suggested that SDF is more effective in anterior teeth. These are anterior teeth where we're able to achieve isolation. We do not need that much of challenge. But look at the picture, 3 of us. It took 3 of us to do SDF. So it is really challenging in patients like this, and especially in a patient with cerebral palsy or any other condition, special need patient. I work on special needs and I know how challenging they can be sometimes and require more manpower. So the main challenge in this case, it's the posterior teeth. We needed to do the isolation. We achieved it later on, but it's very difficult. And these are some of the challenges that you can face during applying SDF. A simple procedure, quick, but yet requires a lot of attention. And then the challenges, as I mentioned earlier, this is just tooth isolation, polypharmacy, medically compromised, depressions. Just like the other case, this visual for you on the right side, it's just to understand rather than memorize. Caries is a balance between protective factors and detrimental or risk factors. In many of these patients, most of the presenting factors are detrimental. So SDF here fall onto the protective factor and will keep that balance in order for the caries not to progress or even to even out the seesaw over here, even out the balance for the detrimental factors for this type of patient. So these cases that I'm presenting for you today can serve you by showing you what SDF can do in a non-traditional environment and how you can further apply these practices in your dental clinic. You're not going to see patients like this all the time, but if you see patients like that or even less extreme, you probably can be able to treat SDF, to treat it with an SDF. This is the research that I have done during my residency at UT Health San Antonio, and it's we wanted to assess the effectiveness with the help of the faculty, of course, and we wanted to assess the effectiveness of silver diamide fluoride in arresting dental caries in residents living in nursing homes, and we did achieve a success rate of 82% after a single application of 38% SDF solution. We originally have 40 patients, but we lost 1 to follow up, and we end up having 39 patients They have 207 teeth, but we only included 188 teeth to ensure that each treated tooth paired with a control tooth in the same oral environment. And we found the average, the average number of a drug and xerostomia inducing medication was taken 4 per each resident. 90% of the caries lesion in the anterior teeth were arrested compared to 77 in the posterior. And that's aligned with the American Dental Association that I just spoke about it, that anterior teeth are that SDF more effective in anterior teeth. And then also, all the non-arrested lesion in the anterior teeth were ICDAS 5, category 5. And that's also aligned with the American Dental Association scientific affair when they said there is low certainty of using SDF in an advanced cavitation. And we know because that they are so advanced in the cavitation causes exacerbate the caries disease process. And of course, the treatment acceptance was very high rate. And I understand because we probably did it in a nursing home and those patients has no other alternative treatment, but literatures and research suggested that there is a high rate of acceptance due to the ease of application. So the takeaway points from these two quick, sessions that I did for you guys just to see what we can do with SDF and how can we apply it in a situation like this, in a unique situation. So it shows that SDF demonstrates success, particularly in anterior teeth. Challenges, yes, there is challenges with applying SDF. It's a simple procedure, but yes, there is challenges in the advanced cavitation, posterior teeth, patient compliance, behavioral health complication, and medical and personal factors. We need further research, definitely, to optimize the use of SDF as a, as a non-restorative treatment, specifically for advanced lesions and for medically compromised patients. But overall, SDF presents a safe, effective, minimally invasive treatment options that arrest and reduce the burden of antedental caries in both pediatric and adult patients. Thank you. I hope I did not go over.
Thank you so much, Dr. Shakir.
Problem. I have the
Awesome.
references. If anybody needs anything, it's there.
Thank you. Let's open up the floor to questions. Anybody have any questions for Dr. Lewis? And
I have a
Dr.
question.
Shakir? Yes, Dr. Amechi.
Hannah, when you did your study on arresting caries with SDF, how did you measure the arrest to distinguish between arrest and non-arrest?
Okay, that's what I show you guys that I see this. Unfortunately, I don't have much time to describe that. What we did, first of all, I want to thank UT Health San Antonio because they have a grant that they can actually go into the nursing home facilities in San Antonio, Texas. And we did them in 9 of those facilities. And they have a team that goes out there to help those people in the nursing home who do not have dental insurance. And Dr. Chawla suggested that if we can do this in the nursing home, that would be great. So we did that one. How did we assess if it is arrested or not? We use Gentili probe, and also we identify the color. If the caries arrested, if it's a black, and when we use it with the probe, we pass the probe over the tooth surfaces, and if it's hard inconsistency, then it is arrested. That's how it's all visual and tactile. We did not do any x-rays. The only x-ray we took in the beginning at the baseline to ensure that there is no pulp involvement, because we do not want to put SDF on a pulp encroachment tooth. So it's basically just visual, and it's a pilot. It's a very small studies. So we just did them with the available patient that we have.
Thank you. Any other questions? Before we stop? Taylor, could you please share the conclusion slide for us? Thank you to everyone for joining us for the 21st Dendeco. Please complete the post-session survey. The link, I believe Taylor just shared in the chat. And we hope to see you in 2 months, in September for the next Denteco. Thank you again to Dr. Lewis and Dr. Shakir and to everyone, for joining today. And I hope you have a great rest of the day.
Thank you.